and looking at non-communicable diseases, and certainly caries being chief among them. So, gum disease, this is from the first edition. There's lots of, what was periodontal disease, what, number 6 on the list, I think? Yesterday we saw. And so as a periodontist, that's all near and dear to my heart. But just to go through this and see that there's a lot of gum disease all over the place. And this is the thing, in non-Western diets, when I worked, did a lot of clinical dentistry, when we had lots of Asian patients, particularly East Indian, as well as Chinese, they didn't have a lot of caries. But boy, they have periodontal disease. And so it's a very different, depending on what your context is, you're going to have one thing or the other, and in the worst case scenarios, you end up having both. And so you got severe periodontitis, basically, particularly the South American countries really have a significant amount of periodontal disease. Tobacco use. Oh, it's interesting, coming from the States, where now we're down to 23% of the people smoke. And I know in Europe, it's changed to some degree. I know, I guess here in Ireland, you can't smoke in public places, is that correct? Yeah, so I saw the guys outside the bars all smoking outside the bars, whereas in the old days you could smoke inside the bars. So things are changing there as well. But still, cigarette consumption and tobacco consumption is different. How many of you folks have smoked in your lives? Raise your hands if you don't mind me saying. Okay, and how many of you have stopped? Most of you? Okay, all right. Difficult to stop. But why did you miss, any of you who stopped, did you miss smoking? Yeah, you miss it. Why? Because it gave you a little buzz, didn't it? I mean, that's the thing, is people who don't smoke don't realize, why do you start smoking? It's because it gives you that little buzz. And the problem is you have to smoke more cigarettes because it takes more cigarettes to get that same buzz. You know, the other things being cool and all those other cultural things that go with it. But those people who don't smoke don't understand that little physiological thing that goes on with smoking, the comforting feeling with that. And then, of course, there's that. So we're very much, we're all, wagging our fingers at people who smoke. But there's certainly reasons that people smoke. The other issue is that, it's interesting that people who have less money tend to smoke more. We think that it's counterintuitive, but it makes sense on a couple of levels. Number one, people who have less money, first of all, usually that correlates with education. So even though we've known about the hazards of smoking for 50 years, sometimes it just doesn't seep into certain people's consciousness. But the other thing is, some people look at that as their only luxury in life. So there's another psychological component to it. Well, I can't do anything else. I can't go to Dublin for the week, or whatever. So I'm just gonna go get another pack of cigarettes. But that's there. So there's a lot, just the physiological, the addicting parts, but there are also some, other things going on in people's minds about smoking. So there's a lot of tobacco smoking going on, and so also oral cancer. So all of us, one of the easiest things to do is to screen for oral cancer. But one of the most frustrating things to do when you're doing international projects is, all right, you found this person with a lesion that you know from just your experience is cancer, or most likely is cancer. Now what do you do? That's the problem. Because yeah, we can find it, but how do you help that person get treated? Is there a facility? Can they afford to go? Can they afford the follow-up? There's I don't think I have the answers to this, because I don't, but there's a whole host of issues that arise. Yes, we did oral cancer screening. Look at the homeless shelter. You do your oral cancer screenings at the homeless shelter. You have a system here, at least in Dublin, where you can refer people. How effective that is, I'm not sure, but the point is, there is some infrastructure here that can help those folks. But in many places, localities, where's the infrastructure to help them? Yes, go ahead.
From an ethical point of view, when you are screening, you have to be able to, before you screen, you have to know where you can refer on, because it's not fair from an ethical point of view to find that and then to not be able to refer them. And so it's difficult, but you need to do that. Can I make one more comment about the Coca-Cola? Sure. It would be really nice if an organization like this can group together and get a grant from Coca-Cola to be able to help with oral health care globally, because every issue is related to the sugar. So it's another ethical issue. Do you want to do business with Coca-Cola? But I think that we should embrace it and look at opportunities for that.
Right. Right. I think one of, in at least in certain parts of, I say, Italian culture in the United States, you keep your friends closer, your enemies closer, and I think that's kind of the, the same idea here. But yeah, it's interesting that the foundations, Pepsi Foundation, the Coke, they're interested in funding projects. They're interested in doing this. They really are interested in doing this kind of thing. So I think you're absolutely right. That I think it's something that the ICD could look into, as far as either doing it as a group, or the other way is again providing the wherewithal to say, okay, this is where you go. This is how you write this grant. This we'll put the templates out here, or something like that. I think that's an excellent point. And I think also about the ethics of dealing with things. Yes, okay, we found it. Now what do we do about it? And that truly is, and it's a problem. But the thing is, sometimes you stumble upon things accidentally.
Is it not difficult with people that may not be highly educated to try to show them that Coke is the problem when you're also using Coke as the solution to a problem? How do people distinguish between the fact that outside your dental clinic you've got Coca-Cola and you're trying to treat the disease? Are they not associating Coke with health?
I think that's a very interesting question. I think we should be fortunate to have that problem more often, but realistically, that could be, and that's where I don't know. Again, I don't know if anybody else has any answers to that. But how do you do it? Because you have Coke outside that clinic, the big sign. But how do you make it so that people realize that, well, Coke is helping to provide this service, it really is not something that you should be drinking. But I think there's in most of these areas, it's the more basic issue of people going to do what they have to do. When you're further down on Maslow's pyramid, you're going to do what you have to do. And if that's all you can afford, sometimes that's what happens. But I think the underlying issue here is that there's no free lunch. That if we accept money from certain corporations, I mean, for whatever reason, I'm not suggesting that there's all kinds of nefarious things going on, but there's no free lunch at all, and that whether it's Coke or another company, that they're going to say, well, okay, we'll be glad to give, but we're going to have our logo out there, and it does create mixed messages, and you don't have to say a word because the people will notice, and they will process it. They will process it themselves, and then see what how that works. So on the one hand, you say no, you shouldn't drink Coke because it's bad for you. On the other hand, say, wait a second, you're right. We got all these Coke chairs sitting out here. So what's the message? And I guess that's part of what you have to do. And this is where we get stuck, because you can't do your work without getting the sponsor. But is that the sponsor you really want to have? And that's. It's a dilemma, and unfortunately, we don't have enough time today to work through that dilemma. That's a great question, though, for an ethics class. I mean, seriously, whether it's here at the college or anywhere else, what do? They want to do this, but they want to get that. What's the ethical dilemma there? Very quickly, because we have to move on.
The issue about toothpaste is a real issue, and whilst, of course, we want to support all the people who support us in our dental career, there must be a way of manufacturing toothpaste in a dispenser that can go to the masses for sponsorship for those kind of issues.
I turn to Simon, not for the answer, but for something to think about. Very good thought. Yeah. Okay, and that's something. The other thing is I will tell you from a purely practical standpoint, moving toothpaste is expensive because it's heavy. Moving toothbrushes is easy, because they're light. I know, and the Colgate and other companies, probably Colgate in the Dominican Republic, is very generous doing things. There's no question. Colgate has done tremendous work as far as that goes. But again, it's a balance. And we do not live, when we're doing these kinds of things, we don't live in a perfect world. That's absolutely the case. And certainly I want those who are not in the room to understand that what we're talking about is messy. What we're doing is messy. And if you don't like messiness, this is not the kind of business that you want to necessarily get yourself involved in. So I'm going to move ahead just a little bit here. HIV certainly is an issue in lots of countries. I think we have a much better understanding of it. The issue now is, can people be treated? And if they are treated, they can live successfully for many, many years. You know, the whole knowledge base of HIV and understanding HIV has changed dramatically in the last 30 years, where at one time it was a death sentence, and now people live with HIV for many, many years, even decades. So I really don't want to spend a whole lot of time here today. But just to briefly mention, you know, the oral effects of HIV and AIDS, you see this. You know, you've got, obviously in many cases where we are, we're not going to be measuring CD4 counts or viral loads, but if you see unexplained candidiasis, severe periodontitis, hairy leukoplakia, and Kaposi sarcoma, you know that these patients have some sort of immune defect or immune compromise. In many cases would be HIV, or in full-blown AIDS in this case. This is a Kaposi, very large Kaposi sarcoma. And Candida. Birth defects. I just want to spend a minute on birth defects. You know, there are organizations, you know, in the States, there's Operation Smile and Smile Train and those, and I'm sure in Europe there are organizations as well that do these kinds of things. For those people who are born with birth defects, depending on the culture they're in, this is almost, I won't call it a death sentence, but certainly creates problems, because these kids are shunned because there's something wrong with them. And so this is where literally these surgical teams that go and do these cleft repairs are basically saving these kids' lives, saving them from a life of basically nothing. And so that's really, I think it's really critically important. As Jill had mentioned earlier, you know, at one time there are problems with some of these organizations, because they would go into areas and do all this fancy surgery, but then they would go home. But there's a lot of follow-up that has to happen when you do sophisticated surgery. And I think now OpSmile has learned their lesson, and they're doing a much better job of leaving infrastructure behind, leaving training behind, training the local docs to be able to be the operators as well, and not just, you know, pulling out, oh, we've done all these great clefts, and then pulling out and not leaving anything behind to help with the aftercare and the speech therapy and the other things that all have to go into dealing with patients like this. But this is something, and even in the Dominican Republic, this is a very big problem, where the cleft kids are basically, hidden, I guess is the best word. Yeah, literally put in the closet, almost, to speak of. So there really are some significant cultural effects. And so I just mentioned here several of the organizations that are involved with this, at least in the States. I'm sure over here there's similar types of organizations. I mean, it's great work. There's no question it's great work what they do, but this is labor and time and cost intensive. No question about that.
In Noma in Africa, the same thing.
Right. Right. Mentioned just about Noma as a problem in Africa. There's no question about that as well. And one of the organizations I'm going to mention at the end is, I think it's called No Noma. It's one of the European organizations that's, I think Miguel had given me that information earlier on. This is my friend, Dr. Samo Lind, and this is a kid that he had followed over time. He's an oral surgeon, and that's where, you know, you can see where he started, and this is where he ended up a couple years later. But this is very intensive surgery, several surgeries to get this kid into good shape, but basically saving this kid's life. Now, the economics of all this, we know that dentistry is not inexpensive. It's not inexpensive anywhere in the world. It's an expensive proposition, but there are ways, and we have all found out, those of us who do this kind of thing, we have found out how to make it much more economical. We've had to, because there's no way we couldn't. We can't do our projects without making it. But just looking at the cost of things, and in the U.S. certainly it is quite expensive, as well as I'm sure here in Europe things are not cheap. And here's just the burden of oral problems. And this is the thing to remember. You know, we deal with not just pain, but the economic impact of oral disease. Lost work days, lost school days, pain and suffering, all those kinds of things. So there's quite an impact. So we can make certainly inroads into communities. If we can help to prevent some of these problems, it's certainly, there are far-reaching implications for what we can do. And so this is just, this review's similar to what we were talking about yesterday. Whoops, I hit the wrong button. Excuse me a second there. Let me get back to this. You know, this is looking in 3 billion people are affected by untreated decay of primary and permanent teeth. That's basically half, or a little more than half of the world's population. That's a lot of folks. There's a lot of dentistry to be done out there. But there's no way there's no way we can drill and fill our way out of these issues. So we have to think about this from a prevention perspective. Now this is just an interesting map of London, and it just talks about where just based on neighborhoods. This is just various neighborhoods and how the needs and the access to care in London changes basically just based on certain neighborhoods. And that is changing. Here in Europe right now, the challenge here is how are you going to absorb the refugees from Syria and other places? I mean, it is a big issue because they're coming with nothing. And they're changing the fabric of society here. Just like in the States, we have been struggling with immigration from the South, Mexico, Latin America, South America. Similar types of things. Legal, illegal, documented, undocumented. That doesn't matter because once they're there, something has to be done. In my current job, I work in a community health center with lots of Latino immigrants. I speak Spanish probably 70% of the. My Spanish is awful, by the way, but I speak Spanish about 70% of the time. And you know, so these people and the way our clinic works, everybody has to pay, but fortunately we have some grants to help subsidize care. So we've made it much more affordable. But it's interesting that even when you make it affordable, or at least what we think is affordable, so many people still can't come up with the $30 for the filling. So that's that's something to look at. And this is just a very quick look at just one locale, and then looking at the cost of a toothache. Somebody gets hospitalized, boom, the costs go through the roof. And in the States, right now, one of the focuses on keeping people out of emergency rooms. Go to the, how do they get to a dentist? The problem is people who go to the emergency room usually pass 5 or 6 dentists on their way to the emergency room. And either they're not open, or they don't take public assistance, or they're not going to see indigent patients. So there are lots of, again, for whatever reason, I'm not being critical, I'm just saying, that's just stating the way it is, and I'm sure it's no different in other countries. But this I think is a really nice graph that regular checkups just cost $50 a year, but then you hospitalize somebody and it's all of a sudden it's $5,000 for that toothache. I can assure you in the States it's a heck of a lot more than $5,000. You basically $5,000 to go into the emergency room the first time, and then after that, especially they do CAT, I mean, they do all kinds of things for toothaches. So anyway, so the impact of oral disease, we talked about that. I'd like to move through this, but again, there's no question socioeconomic status and health, or overall health and oral health are directly correlated. There's no, draw the line, plot your graph. No question about that. And then here, the cost of disease in the EU. Dental disease is the third most expensive disease. The cost, the overall cost. This is morbidity costs as well as treating costs. Is the expenditure 79? What's that? I can't see that from here. Is that billion? Euros. That's a lot of money. I got a little bit. I got half that in my pocket, but it's still a fair amount of money. Do we have enough money to deal with that? And then you put diabetes on top of that. I mean, the diabetes is the one that's going to bankrupt us all, and that's because of all the ramifications of diabetes, not just the diabetes itself. And then just looking at out-of-pocket expenditures. This is again from the second edition of the Atlas. And so I just want to go through this and finish that. But the first part here is setting the stage. We realize it is a big problem. There is no question it is a very big problem. We struggle with this every day in our practices. We struggle with this in our professional organizations. Those of you involved in public policy or on the public sector are struggle with this all the time. But looking at that now, what I want to do now is shift gears a little bit and talk about international volunteer projects and then how to get involved. So, why do you volunteer? The reasons are as varied as the volunteers are. If you don't mind, I'm going to pick on a couple of you guys. So how did you get started with your project?
We looked at the need in terms of, I looked at what I could do to give back and how I could help. And then I took advice and took opinion as to what is the best basic help that can be given.
Great. And so you want the desire to give back. Somebody else with a different, with another reason you got involved in this. So just raise your hands and And that's the thing. I told you yesterday. One, I like to travel. I mean, I make no bones about it. And I was lucky. I started doing this when I was 28, which is usually, it was very unusual. Most people do it mid-career, late career kinds of things. I was lucky. I started doing it when I was 28. And so I like to travel, and I said, I might as well do something interesting while I'm traveling. And the nice thing about dentistry is we have portable skills. Yeah, we need a little bit of equipment. We don't need a lot. We don't need an operating theater or anything like that. Basically, I went the first time to the Dominican Republic with 3 little boxes of stuff. Some of you remember AutoCure, Adaptic, and Concise, those kinds of things. Imagine using that. It's 95 degrees and 95% humidity. Boy, did I have to work fast. No good. You're pulling it out of the centric syringe, and it's polymerizing as it comes out of this. Some of you guys are flashing back to those days. You remember those days. So, I was able to just go with relatively small amounts of things. For extractions, obviously you need relatively, little armamentarium. But I wanted to travel and do something useful at the same time. So that's how I got involved with it. So give back, as you just mentioned, or paying it forward. I don't think we can give back. All we can do is pay it forward, realistically, is that if you think of it in those terms. And then the realization, I wrote this when my kids were younger, realization that there's more than going to work, driving the kids to soccer practice, cashing that stripe, I lift a fish, by the way, or lowering that golf handicap. And again, be part of the solution and not just part of the problem. And then interest in traveling, meeting new people, and doing something worthwhile. Supporting, some people support a church organization, a church mission, or humanitarian service organization, like supporting the Capuchin Center. Obviously, that's going to be a faith-based center. But part of it is, especially if you get involved in the training education projects, and we'll talk about those a little bit, interest in sharing knowledge, skills, and experience with international colleagues. And as you know, obviously, dentistry in Europe is very sophisticated, but I can also tell you, those of you who've been to Vietnam, dentistry in Ho Chi Minh City is also fairly sophisticated. Dentistry in other countries, in other areas, is very sophisticated. And so you're working at a different level. And so that's part of the fun of it. And I've had the pleasure of doing both service and training projects. And people participate based on experiences related by someone else. It's easy to get people jazzed up about this kind of thing. And those of us who have done it, we have this commonality, and we could talk for hours to each other about, oh yeah, and then when this, we could spend hours, well, a few pints, more than one pint, I suspect. But although I'll be trashed after the second, I'm a cheap date, I can promise you that. But the thing is, we go because other people are interested, and it is a fun thing to do. I hope most of you guys have as much fun on your projects as I have on mine. Why? It's a heck of a lot of work. There's no question it's a lot of work, but gosh, is it fun. I mean, I look forward every year to going to the, and why is it fun? Because especially if you go back to places, you see your friends, number one. Number two, you go for the puzzle. You go for the challenge. Every day we go to a different site, and we're a mobile clinic, so we don't stay in one place. We go to a different place every day. And part of the fun for me is I stand there for the first 5 minutes, and I just look around. And I say, okay, where are we going to do this? And we have everything. We have operative, we have pros, we have pedo, we have surgery. And so I just spend the first 5 minutes with a couple of my guys, and we decide where the generators are going to go and where this is going to go. And then, boom, half hour later, we got a clinic. And that's for me, that's part of the fun of the day, the whole problem-solving challenge of the day.